Behalf of the Scouts, uh, I'll be very warmly welcoming you all for this first ever Uromet program or urology um, monthly education for trainees. Uh, am I clear and audible?
Yes,
Okay, thank you, sir. Right. Very good afternoon for all of you all, and uh, please welcome our expert panel today. It is Dr. Amrita Pegunsekara, and thank you very much, sir, for joining, and Professor Neville Pereira, and yes, I think just joined. Um, and thank you very much, sir, for joining today. So before starting the whole program, I must just mention the brief history, uh, very briefly, about the urology teaching programs in the country. Um, and first ever urology teaching program which I have actually participated was my dear teachers Cubs Club, which is about 10 years ago. And I must mention that which has really inspired us for the urology, and in fact one of the key reasons that why we are being urologists today is due to that inspiration um, about the subject, about the vast variety and the clear content. So that is the first ever program which I participated. So that is something which must be mentioned here today. And then the second is the Trend Journal Cup, which is conducted by Dr. Anuruddha Begunasekara, which is again a very nice opportunity for all the trainees to come and discuss about the one of the key papers and share some thoughts and some important discussions about some important clinical scenario. So those are the two teaching programs that we have experienced in South and during our teaching or training career. And then this is the evolution of the same program, and this is urology monthly education for trainees for Uromet, brought by the South and the academic committee of the South. So you all are very warmly welcome for this first ever Uromet program. And so just briefly mentioning you why that we are doing this Uromet program is most of our actually this is something which we have experienced after the training. Once you finish your local training and when you go for the overseas training, you'll be regarded as a very highly qualified or highly skilled colleague. But at the point when you finish your training, you will really feel like you should have got much things and you should have got much skills had you had some sort of a structured teaching or a core training program. So so that is something which I really felt, and which most of the many of our trainees who returned has felt. So that's why we started this sort of kind of a teaching program for the trainees, and this is all for the benefit of the trainees. And trainees, please take the maximum benefit of this program. And all these experts and the eminent speakers are here, and they are here for you to help you all. And please try to get the maximum out of that opportunity. And and again, I would like to thank the president and the secretary of the SLAUS to uh, show such an enthusiasm to bring this thing and make it possible. And also Dr. Anuruddha Begunasekara for the guidance, and Dr. Bala Gobi for, yes, basically done the program single-handed. And thank you very much, Gobi, for arranging all this. And also Sikla for giving us this wonderful platform to discuss. And as the time come by and as we go along, I hope this would be much more sort of interactive, and many more practicing urologists will also join, where we can discuss things and get ourselves updated. about the recent sort of ongoing things in urology and get ourselves updated. So without further ado, I would like to invite Dr. Balagobi to start the first session and to carry on with the program. And thank you very much.
Thank you, Dr. Nisanda, and welcome dear teachers and friends. So this is the first Uromet. We are going to discuss about renal cancer. First of all, I have to tell that as a Sri Lankan trainees, I felt we are 10 times competent in skills, but we are 10 times weaker in knowledge when I have been in UK. So still I feel that we need more knowledge and the people outside Sri Lanka, especially the urologists in India and European countries are far better in the knowledge than ourselves. So we have to upgrade our knowledge, and this platform is everything is for our trainees. So please show your enthusiasm. So more you are interested, more we can do. Today in our session, we are having two experts. And without further delay, we are starting the session. So we have four major topics. The plan is the trainee will present his topics. Then there are the experts or moderators might ask question on that speaker. Then between the topics, we will discuss about, we will get the opinion from the experts on the specific points about the topic. So first we start with the first topic, renal cancer core topics, which will be discussed by Dr. Gihan. So Dr. Gihan, please share your presentation.
Yes. Hello. Good evening. Can you hear me?
Yes, we can hear you.
Yes. Good evening, everyone. I'm going to start with the renal cancer introduction to malignant tumors. So, historically, Viscott in 1961 documented the first nephrectomy, which was accidentally done nephrectomy, thinking it was a hepatoma. And first planned nephrectomy was done in 1969 by Simon, which was for benign cause ureteral fistula, and the surgery has been successful and patient lived. So even before that, Robin in 1855 identified that renal cancers are caused by tubular epithelium. However, a historical mistake was made by Gravis in 1880s, coining tumors into hypernephroma, which was thinking it was arising from adrenal gland. It took some time before it was considered again back to tubular epithelium. So in modern day, tumor biology is evolving very fast, and very advancements are there. So nephron sparing surgery, minimal invasive surgery, and immunotherapy are advancing fast and plays a major role in renal cancer management. However, renal cancer remains primarily a surgical disease, and still mortality is high. So classification of renal masses, actually, there are several attempts at classification: malignant, benign, and inflammatory masses, or simple cyst, complex cyst, and solid lesions. Then this is the renal masses classification. Basically, benign and malignant tumors arising from different components of the renal tissue. Renal cell carcinoma, I will discuss further in detail specific types. And we cannot forget the urothelium-based cancers often we see in our clinical practice, and sarcomas very rare. And in children, nephroblastic tumors, nephroblastomas, and neuroendocrine tumors, neuroblastomas, pheochromocytomas, and some malignancy, hematological malignancies can occur in tumors as well. Secondary tumors can cause by metastasis or by adjacent neoplasms, colon, or other organs. So benign tumors are classified by cystic lesions, solid lesions, vascular and inflammatory masses, solid lesions, angiomyolipomas, and oncocytomas we see in our clinical practice, and inflammatory xanthogranulomas pyelonephritis are common. Imaging and risk stratification.
So Gihan, so sorry to interrupt. Yes. So if someone asks you, tell us 2 common benign tumors of the kidney, what will be your answer?
Angiomyolipomas and oncocytomas.
Okay, very good. Yeah, proceed.
Then imaging and risk stratification. Male gender has 3-fold increased risk of having a renal cancer, and tumor size has a predilection for being malignant tumor. If it is renal mass is less than 4 centimeters, that is 20 to 30% chance of it being malignant. And if it is it being benign, and if it is less than 2 centimeters, there's a 40% chance of it being benign. So size matters. And then likelihood of malignancy increases by factor of 1.3 per centimeter. And also this is the basis of this less than 4 centimeter cancers, or small renal mass, which behaves more like a benign tumor, and only 2% had developed metastasis, even though it's renal malignancy. So radiographic evaluation comes first nowadays, because about 60% of the cancers are incidentally detected renal cancers. So strongest predictor of malignancy and its metastatic potential is our radiographic evaluation by cross-sectional imaging by CECT or MRI. And other modalities are used in initial phase, like in ultrasound scan and the contrast enhanced ultrasound scan, but of course their predictability is low. And intravenous pyelography and renal angiography only in resource poor settings as initial investigations. So what are the features that we are looking for in our radiographic evaluation are enhancing masses in a CECT, 15 to 20 Hounsfield units. And if it is...
Gihan, sorry to interrupt. What do you really understand by enhancing mass or enhancing?
Yes, that is with the contrast agents, we take triphasic CTs in the non-contrast phase, arterial and venous contrast phase. In the arterial phase, it has usually renal parenchyma will enhance or the contrast material will light up the renal tissues, and that is what enhancing is mean. In the arterial phase,
which means there's a background non-contrast phase is quite important.
Yes,
because what you are looking at is actually enhancement from the background non-contrast phase to the contrast phase. So
yes,
the difference is what is called the enhancement. Thank you.
Enhance. Yes, sir. And if it is minus 20 Hounsfield units, more suggestive of fat tissue, suggestive of angiomyolipomas, so lipomas. And then again, in the MRI also enhancement, 20% enhancement from baseline with gadolinium-based contrast is considered significant predictive of malignancy. And then this is just when we are doing MRI, we have to be aware of nephrogenic systemic fibrosis, especially these can be complicated patients on dialysis and CKD stage 4-5, or patient may be in AKI, which will aggravate these complications. And also before the CECT, estimated GFR is recommended to prevent contrast-induced nephropathy. And there is regarding the radiographic features, ultrasound scan strict ultrasonic criteria. If we incidentally detect a simple cyst, which is called strict ultrasonic criteria for simple cyst, smooth walled, round oval shape without internal echoes, and through transmission with strong posterior acoustic shadowing. If all these features are there, it's a strict ultrasonic criteria for simple cyst. If that is there, we don't have to image further. However, if these strict criteria is not there, we will have to do a CT, CECT to further characterize the cystic lesion, and which will lead to Bosnick classification on CECT findings. And this is the summary of the features I told, whether it's a complex cyst or solid mass. If contrast allergy is there and estimation GFR is good, we can go ahead with the CT, and otherwise with the MRI. And then if it is a simple cyst with a strict sonographic criteria, we can observe. Then the things, further things we look into the CECT are diameter of the tumor, because size of the tumor is a strong predictor of its clinical behavior. And then morphology, association with the renal hilum, and enhancing characteristics, like I told earlier. And then retroperitoneal lymphadenopathy, abdominal metastasis, local infiltration into renal vein. And this renal nephrometry score is introduced to identify the complexity of the renal tumor, especially in the era of partial nephrectomy, which includes radius, exophytic versus endophytic, nearness to collective system, epilocation relative to polar lines, which has a predictive value of whether we can clear it with a partial nephrectomy or not. And then
so Gihan, sorry to interrupt.
Yes.
Is there any difference between the renal score and the Padua score? And why there are two scoring? More or less both are same.
Okay.
But the Padua score is used in European countries, and renal score is used in US.
Okay.
More or less same. And you said about Bosnia classification. So Bosnia classification is based on ultrasound imaging or CT imaging?
It is based on CT imaging.
Yeah. Yes. You can proceed. Thank you.
Yes. And when we look at the image, we are thinking about the surgery and our approach, and also possible complications. And infiltrative growth pattern is not commonly found in renal cancers, but if it is there, it is more suggestive of urothelial cancer, lymphoma, infectious process, so high-grade dose sarcomatoid renal cancer. So this is another way of classifying things with the radiographic criteria, whether simple cystic, complex cystic, or fat-containing mass. Whether it's strongly, yes, sir.
Sorry to interrupt, I'm Supun De Silva.
Oh.
If someone asks you, someone junior to ask you about the typical features of typical contrast CT features of a typical clear cell renal carcinoma, what would you tell him?
I would tell it is a solid mass, renal mass, which is enhancing with arterial phase 15 to 20 Hounsfield units.
Well, more than the enhancement behind, we call it heterogeneity. That means inside the enhancement, you get areas where there is not much of enhancement. Okay. So heterogeneity is the main feature. The other two, I mean, the radiologists go by three main features. One thing is the heterogeneity, and then it is usually well circumscribed, and mostly it is exophytic. So those are the three typical features of a classic clear cell renal cell carcinoma in sick contrast CT.
Okay.
Carry on.
Just to add a few more about your enhancement again, the classic 15 to 25 is just to sort of suspect whether there is a renal tumor. But this enhancement again varies depending on the various histological subtypes. So for example, if you get a clear cell, that is the most enhancing one. Usually if it is enhancing more than 80 or somewhere around 100, it is almost sort of most of the time people tend to say it is more towards a clear cell cancer. Whereas if you take the papillary renal cell, it is not that enhancing. It is very poorly enhancing or somewhere above the 15 to 20 range, but it is not as good as clear cell. So keep that in mind when you discuss the enhancement also. That's some additional.
Okay. So like I said, there are strongly enhancing masses, moderately enhancing masses, and multifocal and bilateral masses, which are more suggestive of familial metastatic metastasis, and then infiltrative masses, like I said earlier, and some calcified masses. Then just an image of exophytic heterogeneously enhancing renal cancer, probably a clear cell carcinoma. Yes, suggestive of renal cell carcinoma, and confirmed to be a clear cell renal cancer. Then molecular imaging PET-CT has a limited role because it enhances tissues which has same enhancing pattern as the metastatic cancer itself, which is visual conspicuity, same visual conspicuity, and then oncocytomas, which are different to differentiate with the renal cell cancer sometimes, can be differentiated with the SPECT-CT with TC cystomy by scan, which enhances the mitochondria in more, which are more found more in oncocytomas.
Yeah, Gihan, sorry to interrupt.
Yes.
So you know about the PET scan, you know about the CT scan. Why they have combined both PET and the CT scan?
Yes, just to identify the metastasis, we can use a PET scan. But if we are planning a resection, we need to identify anatomical details of the organ or relation.
Yeah. Very good. So CT is more anatomical information, PET more functional information. So when you combine, you get more information. Yeah. Thank you.
But always remember that PET-CT is not going to be good enough if somebody asks you, because what you need is two different CTs, because your phasic CT or triphasic or IVU protocol CT is a must, because that is the one which you sort of give all the information about the characteristic of the enhancement and everything. But PET combined with the CT is used just as a tool to, as you said, to identify the anatomical boundaries. So CT IVU protocol is a must, but if you want PET, you have to again combine with PET CT.
Okay. So moving away from renal masses, evaluation of a cystic renal lesion, Bosniak classification is described with CT imaging criteria, thinking about the wall number, septile density, calcification, solid components, and margination. And Bosniak 1 is uncomplicated, simple benign cyst. We don't have to follow them up. And Bosniak 2, again, non-enhancing septated, some calcium on walls, can be infected, and hyperdensity. If hyperdensity is there, then we have to have some follow-up. But otherwise, Bosniak 2 also, we don't have to do anything. But Bosniak 2F cyst has a 15 risk of radiographic progression and 3 to 10% risk of malignancy, which we have to follow up with periodic imaging. Bosniak 3 and 4 has solid walls and enhancing, which have 40 to 50% of having risk of malignancy. In 3, 50%, and in 4, 75 to 90%. In that case, we have to go ahead with the surgical excision because biopsy will cause some tumor spillage and it is cystic, so sampling error is there more than a solid one, so we can't go with the biopsy.
So, Gihan,
a small question, Gihan.
Okay, sir.
Yeah, just if you see a cystic component in a CT, are you worried more or less compared to solid?
With the solid component and a cystic component.
So you get a renal lesion, you're suspecting of renal tumor, and there are solid component as well as cystic. If you get more cystic components, are you worried more, or if you get more solid components, you are thinking of slightly a bad prognosis?
No,
it's just always, most of the time, it's the solid lesions, the solid parts. So you can see in the even in the Bosniak categorization, more it gets solid, more it gets worse from the prognosis.
Okay, yes.
Okay.
So some epidemiology of renal cell carcinoma, it represents 2 to 3% of all adult tumors. And from renal cell cancers, 4 to 6% are familial. Male to female ratio is 1.9 to 1. And common presentation of age is 55 to 75 years of age. It's very uncommon in childhood, but in second decade, 10 to 20 years, it is same as the nephroblastoma incidence. But if it is found in childhood, surgical therapy with lymphadenectomy for positive lymph node disease is the treatment of choice. And then about etiological factors of renal cancer, proximal convoluted tubule is the origin for both clear cell and papillary types. Distal nephron is the origin for chromophobe and collecting duct carcinomas. Established risk factors are tobacco, which increases the relative risk 1.4 to 2.5%, and obesity, a relative risk of 1.07 for each BMI unit above normal. And then this obesity paradox is there, which says when there is obese people with a higher BMI, although they have a higher risk of renal cancers, their stage is low. And then hypertension is associated, but whether it's a disease itself or the drugs are causing, clearly not mentioned or identified. And then chemicals, again, no specific agents identified. NSAID regular use has been suggested as a etiological factor. However, aspirin and acetaminophen were studied and identified they have no effect on renal cancer. However, radiotherapy in stage renal disease are some other risk factors which are causing renal cancers. Then familial and molecular genetics, which are evolving due to recent target agents. So we have to know some more details. Knudson's two-slit hypothesis, again applicable to VHL gene and VHL protein. Although it's familial described, but it is also common in clear cell renal cancer sporadic types. VHL Von-Hippel-Lindau disease can cause renal cell cancers, pheochromocytomas, retinal angiomas, hemangioblastoma of the brain stem, cerebellum, and spinal cord. And 50% of them develop renal cell cancers in third to fifth decade. and the more common bilateral and multifocal tumors. And this VHL gene will produce VHL protein which inhibit hypoxia-induced factor. As its name suggests, hypoxia-induced factor is produced more when there is tissue hypoxia, and which has once it dimerizes, it produces growth factors to increase VEGF, vascular endothelial growth factor, and other growth factors like PDGF and TGF, which has effect on angiogenesis as well as tumor cell growth. So autonomous tumor cell growth can occur when there is hypoxia-induced factor more. So a deletion of VHL gene will cause more hypoxia-induced factor to be accumulated. Similarly, IMTO pathway induces hypoxia-induced factor. So some cancers go through that pathway, like tuberous sclerosis complex. And also this pathway is very important when we think about the target therapy of renal cancers. We can target IMTO pathway, we can target VEGF receptors. So it is important to identify that.
So Gihan, in VHL syndrome, what is the histology you get? Or is it a clear cell or papillary or chromophore? Clear cell. So you said an important point that even in a sporadic cancer, they have this VHL mutation. So that's why most of the time, targeted therapies have a better effect with clear cell histology rather than other histology. Yeah, thank you.
Yeah. So there are some other genes described like PBRM1, BAP1, SETD2, and chromatin remodeling and methylation. So these are the manifestations of low multiple Lindau disease, like I described earlier, visceral and central nervous system tumors. And important to recognize that pheochromocytoma is one of them. If we have a suspicion of this VHL-induced renal cancer, we have to exclude pheochromocytoma even before doing something. Other syndromes include the hereditary papillary renal cancer syndrome. Type 1 papillary tumors are there, and autosomal dominant tyrosine kinase domain of c-MET proton gene is mutated there, but they are less aggressive than sporadic counterparts. And then hereditary leiomyomatosis and renal cancer, which has association with cutaneous uterine leiomyomas and type 2 papillary tumors. Mutated gene is fumarate tyrate, and prompt surgical management is necessary because these are very aggressive tumors. And succinate dehydrogenase renal cell cancers are described, which has a Warburg effect, which when in generations to come, the aggressiveness will increase when the father has the son has the more aggressive tumor, like that. So Burtog-Dubie syndrome, again, a collection of diseases, cutaneous fibrofolliculomas, lung cysts, spontaneous pneumothoraces, and regarding renal cancers, it's a chromoprobe renal cancer and sometimes oncocytomas. And also a combination of hybrid tumors can be there. And like I said earlier, IMTO pathway is affected. Cowden syndrome, again, PTN tumor suppressor gene mutation is there with breast, renal cancer, thyroid cancer, 50 to 50, 34% and 10% lifetime risk of cancers. And then papillary type of cancers are found in renal tissue. And then tuberous sclerosis complex, again, angiomas and some other cancers. So histology of renal cancer is the clear cell. And then finally, microphthalmia affected transcription factor associated cancer, which is a combination of melanoma and renal cancer presentation. And moving on to pathology of renal cancer in general, macroscopically.
You have 5 minutes more.
Okay. In general, microscopically round to ovoid pseudocap have a pseudocapsule usually, and then yellow, tan, brown in color when cut surface. And these are not grossly infiltrative. But exceptions, like I said earlier, collecting duct carcinoma and sarcoma differentiation. Moving on to nuclear features, initially Furham's grading was used with the nuclear size, shape, and prominent nucleoli. However, nowadays 4-tiered WHO grading is used. And then local behavior, renal clear cell cancers, they are tend to extend into venous system, which is found in 10%, and capsule and cachexy system in 20%. Sporadic cancers are usually solitary, and if bilateral cancers are found, we have to think about familial and von Hippel-Lindau. And if multicentral cancers are found, which is 10 to 20%, we have to think about papillary and familial cancers. Classically, histologically classified as clear cell, granular cell, tubulopapillary, and sarcomatoid, but which has changed now with WHO classification giving a multitude of cancers, many number of classification. I will discuss common ones. First one is the clear cell. As we know, 80% of yellow, 80% of cancers, and then yellow color, clear cells or granular cells are there, and renal invasion common. It is had bad prognosis than other cancers. However, when metastasis, it has a good prognosis because of that VEGF pathway mutation, and we can target that therapy. And this is a clear cell renal cancer with the yellow color cut surface. And then papillary cancers, which are 10 to 15%, like I said, multicentral, and type 1 basophilic, MET mutation, hereditary papillary renal cancer syndrome association, and better prognosis. Type 2 eosinophilic, hereditary leiomyoma renal cancer syndrome, and worse prognosis than clear cell cancer. This is a papillary cancer with bilateral involvement. And chromophobe cancers, 3 to 5%, which has a perinuclear halo in histology. The image shows that. And which the pseudocapsule also seen in cut surface. And when they are localized tumors, they have a better prognosis than clear cell cancer. Collecting duct carcinomas are very aggressive tumors arising from collecting ducts of Bellini, positive for E-cadherin and c-KIT mutations. Like these are epithelial cells, so they have these proteins, and then multimodal treatment is necessary. Medullary carcinomas, again, associated with sickle cell trait, and they are very highly infiltrative. Presentation, 60% incidentally found, and classical triad nowadays is less common with pain, hematuria, and loin mass. But some important presentations are like 50% of unclear perirenal hematomas ultimately found to have renal cell cancers. And IVC obstruction can be there with bilateral oval lymphedema and features, and varicocele can be there. Paraneoplastic syndrome, most common one is the elevation of ESR. Hypercalcemia can be due to either paraneoplastic syndrome or metastasis, and hepatic dysfunction or Staphylo syndrome can be associated. And renal cell cancers also can present with systemic features like persistent cough, bone pain, fever, cervical lymphadenopathy, and weight loss. So because of these unusual presentations, it was initially called internist tumor, more like a medical thing than a surgical. Then staging, Robinson staging was previously used, now turned into TNM staging. I will TNM staging for the moment. However,
so if it is infiltrate the renal sinus or renal hilum, so what's the stage?
Stage
it's 3A.
Yeah, 3A, yes.
Okay. So if it is infiltrate the adrenal gland,
it is T4.
T4.
Yes.
Right. If it infiltrate the IBC wall of the IBC.
T3C.
Right. Okay. Thank you.
So then this is the evaluation of this TNM staging. When it is ordered on 5-year survival, you can see the latest one correlates more with the 5-year survival. It starts from T1, A, B, C to T4. So that is more used nowadays. And then prognosis, all the factors that I discussed earlier come into prognosis factors clinically, anatomically, and histologically. Important things are like multivariate analysis for pathological factors have a better predictability for prognosis than individual factors. So because of that, University of California, Los Angeles classification integrated staging system has been introduced, which uses TNM, performance status, and grade of the tumor to categorize them low, intermediate, and high risk of progression. Similarly, Mayo Clinic criteria for stage, size, and grade necrosis score, SSIGN score, which gives cancer-specific survival rates. And then
now, Gihan, if there's a sarcometric features are there, what about the prognosis? Good or bad?
It's bad.
Tumor necrosis?
Again, bad.
Type 1 papillary or type 2 papillary is a worse prognosis?
Type 2 papillary is worse.
Right, okay.
Then symptomatic presentation can be there due to more than 10% of weight loss and poor performance stages. Symptomatic presentation is a bad prognosis time. And pathologic staging is the most important single most important prognostic factor. Venous involvement is not bad as previously thought because 45 to 69% of 5-year survival with proper treatment. And then infiltration of renal vein is more important than extent of thrombus. That's why renal vein infiltration come into T3C. And then T4 or metastatic cancers, markedly prognosis drops. So, but there is increasing role of VEGF target treatment, which increases the survival. And that concludes my presentation.
Thank you, Gihan. It's nicely made presentation. Now we ask expert anything to add or anything to ask, any more question to ask from Gihan or from the trainees, Neville sir and Arvind sir.
Can you hear me?
Yes, sir.
Yes, sir, we can hear you.
Congratulations, Jan, for your very comprehensive presentation. Now, I've just sent this question about knowing the genetic basis of renal cancer. So, as you know, still the metastatic renal cancer has a very bleak outcome. So, whether these knowledge on genetics in future will be useful in genomic pharmacotherapy is something we have to sort of explore and see. There are a lot of experiments going on, like in breast cancer, to understand the genetic basis and then decide on what sort of drug in metastatic cancer, what drugs will actually act. So I think it's just a comment on the future, but otherwise I think you gave a very comprehensive account on the basic facts on RCC. Anuruddha, you have to make any comments?
Can I ask a question, Gyan? Excellent presentation, Gyan. You said more than 50% of spontaneous perirenal hematomas have an underlying malignancy. What is the histology that is associated with this perirenal hematomas generally? Out of your clear cell, papillary, chromophore, etc. It is actually the papillary. Papillary tumors are the ones which are known for spontaneous rupture, about 8 to 10%. We actually wrote a case report recently. Second question is, Gihan, you said now, sir also said genetic studies are becoming important. Now, when should we, in our clinical practice, think of doing further genetic studies? Say in clinical practice, we see renal cancers. We are not going to do genetic studies in all. Whom should we do? Like, do you have any idea? Practically, where we should start? Like,
Yes, I'm not a strict criteria, sir, but however, I think if you find bilateral tumors or very young age tumors,
what is the cutoff, Gyan? I just want to know, because I am also not sure, because in our country, now you said average age is 55 or so.
75
Yeah,
years.
but in our series, it is very clear. Our average is much lower and our male preponderance is much higher in our series. So we see a lot of young patients, but we can't do genetic studies in all. That is why we couldn't find any genetic problems in some of those. So I was just thinking, we assume our cutoff point as 35. I just want to know whether it is reasonably okay. That's why I asked the question. Balagobi might know, Nishanta?
Yes. Yes, for the breast, they have a cutoff of similar, isn't it, sir? So
yes.
I think, yeah. And BHL present at the age of 26.
Right.
So I think, yeah, better to start before 35.
30 or 35. No? Yeah.
Okay.
Can I ask a question? And we have done some retrospective studies, and how many of these sporadic RCs is you will come across has a family history or some sort of a clue about inheritance? Retrospective studies.
Very low, sir.
Exactly.
But Gihan said it's 3%, 3 to 5%.
Yeah,
but I don't know. In ours, we haven't seen that many.
It's much less, because I think in our series also, I think was sort of nearly 100 cases. We hardly ever found any family history or anything. And regarding these subcapsular bleeding and hematomas, I think even these angiomyolipomas has a very high chance of spontaneous bleeding and having subcapsular hematoma with collapse. I think there is a syndrome.
It's called Wanderlin syndrome.
Wanderlin syndrome.
Balagobi must be knowing, and Nishanta must be knowing. Yeah. So I think we can add that to the knowledge, right? Okay.
Yes, so there's a triad of 3 symptoms. One is, as Sir said, hypovolemia and pain and the loin mass. Common causes are, one is AML and renal cancer, and even pyelonephritis sometimes can cause this Wanderlin syndrome. Yes.
There is another question to the experts. Yeah, the question is, if it is a, let's say, Bosniak 1 simple cyst on ultrasound scan, do you really need to do a CT scan?
I think Gihan just now said not necessary, so we'll stick to that.
Yes. Yeah.
Yeah.
Can
the
I
classification is based on
something
CT.
to that?
Yes, Supun, we can hear you.
Yeah, so about the Bosnia classification and CT, the guidelines and the history says that the first classification, at least you should have one contrast CT to call it either Bosniak 1 or 2 or 3. Then the follow-up can be done with ultrasound. So just the ultrasonographer saying you that it's Bosniak 1 is not going to be looking elegant on documents. So for the at least for the proper documentation for a Bosniak tumor, cystic tumor, you should have at least one CT, and the follow-up can be planned according to the initial grading that the patient gets from the first contrast CT.
I tend to agree with Supun because Bosniak classification is based on CT. So the starting point should be a CT, maybe non-contrast CT even. So because ultrasound is so operator dependent.
Can I add a few more points to the presentation? The convenience.
Yes.
Hello.
Super. Yeah, super.
Yeah. So about the nuclear grading, I think Gihan mentioned about the Furman and the WHO. but the pathologists now tend to towards the eye upgrading for all the urological cancers. So that part needs to be added. And little bit about the hereditary or cancers which has mutations. I came across a patient with the last type that Dihan mentioned, that is the microphthalmia associated translocation renal cell cancers, which are very rare. And it is, it's not purely a point mutation. It's, as the name goes, it's a translocation mutation, commonly seen in the pediatric age group, and it carries good prognosis. But if it is found in an elderly or a, say, middle-aged person, it is not so. If it is detected in an elderly person, it carries bad prognosis. So that is another a type of renal cancers which we tend to overlook most times, but it is there. And I think why we miss that is because we don't do the genetic testing for all the renal cancers, as well as the pathologists are not really looking into it with immunomarkers. You need immunomarkers to diagnose that. So it's a case of we not having that translocation renal cell carcinomas. It's a case of we not detecting it often in many renal cancers. So that's a type of cancer that we tend to overlook when we talk about renal cell cancers. Thank you.
Okay, thank you, Supan. So I think it's time to move to the next topic. Now we are calling Dr. Achyutan to deliver a discussion on the small renal mass. Achyutan, over to you.
Yes. Thank you. Can you see my presentation?
You need to press the share screen option, Achyutan, once you're in full screen.
Achyutan, at the bottom there must be a share screen, green color box.
Yes.
Left.
Oh, okay, sir. Yeah.
Yeah, we can see your presentation.
Okay. Everybody, I'll be talking about small renal masses. So the basic contents of my presentation is a small introduction, the role of biopsy, treatment options, guidelines on active surveillance, which is not clearly defined up to now. There are different ways people are performing active surveillance, and the benefits and shortcomings of ablative treatment versus partial nephrectomy. Partial nephrectomy and the scoring systems which on the basis of which we decide on partial nephrectomy, complications of partial nephrectomy and their management, and what are we going to do when after surgery the margins become positive. So small renal mass, as we already discussed, now renal RCC does not, renal cancer does not present with the classic triad, which we used to learn when we were medical students. Now most of the time it become we detect it as incidental findings in ultrasound done for non-specific complaints or abdominal pain. So small renal mass is more, it's getting more and more common as a presentation, and we have a lot of problems in managing it. So it can be defined as a mass which is less or equal than 4 centimeters in size and detected by imaging. So as soon as we get a finding of a small renal mass, now we have to decide whether are we going to manage this as a malignant mass, as a benign mass, and what is the ideal management, because we have multiple options to manage. And even if it's a malignant cancer, there is difference in the way there is the activity depending on the grade of the tumor and the type of the cancer, which we can't predict based only on the imaging. Our management will differ markedly, even if the tumor is a malignant one. So, and the major important thing is now 30% of the small renal masses are benign. So we can't go for radical partial nephrectomies or anything without a clear-cut decision. So our management will be based on patient characteristics, whether the patient is an old patient or a young fit patient, and existing renal function, whether he's a patient with CKD. And imaging can also help, as we have discussed already with the enhancement and counseling unit. Imaging can also help. And also, if the renal tumor biopsy is available, that will be also very helpful for us, because in experienced centers, renal tumor biopsy carries a sensitive specificity of 99%. And there is also discussion about using genetic and molecular studies also to personalize the treatment for each patient. As I go further, if you consider biopsy, indications will be when we can't radiologically define a renal mass, whether we are not sure whether it's a benign mass or a malignant mass, we can go for a renal tumor biopsy. And when we consider candidates for active surveillance with small renal masses also, we can go for an initial biopsy. That usually we do when the size of the tumor is more than, there are different practices, more than 1 centimeter in size, because less than 1 centimeter, usually we think that this is very low chance of metastasis, and we monitor the mass with serial imaging, and when it passes the size of 1 centimeter, we can consider doing a renal tumor biopsy. And even before we go for ablative treatments, we need to get a diagnosis of the histopathology.
Just a small question, sorry for the interruption. So you said you're going to sort of follow it up, and yes, what sort of size increment that you're looking at?
Our review article I read said up to 1 centimeter, less than 1 centimeter, we can do serial imaging. When it passes the size of 1 centimeter, we can go for renal tumor biopsy.
Yeah.
And after we have
just to add your knowledge, it's just the about 0.5 centimeter, less than 0.5 centimeter, around 0.3 centimeter per year is usually a benign lesion, or not just benign, at least a low-grade lesion. But if it is above 0.5 centimeter per year, it is tending more towards
more than, yes, that was also mentioned, more than 4 centimeters, so doubling time less than 12 months. That is also indication of repeat biopsy or first-time biopsy. That is also an indication. Renal biopsy is not indicated if the patient is anyway decided for conservative management because of his comorbidities and he's frail, and we are only going to do watchful waiting. There is no point in going for a biopsy. And when like we've already discussed, if the CT is very clearly evident of a malignant CA, there is no, and we surgeon no point in doing a biopsy. And general lesions, we don't do trocar biopsy unless there are solid components. In the like Bosniak type 4, there are solid components. We can target the solid components. Otherwise, there is no point in doing a biopsy in a cystic lesion. So biopsy can be performed ultrasound guided or CT guided. Both they produce the similar yield in an experience center. The technique recommended is a coaxial technique to prevent the principle of tumor seeding. So we do usually through a coaxial cannula, 16 gauge cannula. FNA can also, with the combining the FNA with core biopsy, can also improve our diagnostic accuracy. Like I told you before, the accuracy, sensitive specificity goes up to 99% in a well-experienced center. So it will be worthwhile when indicated. We have a very good diagnostic core when the tumor is an exophytic type with larger size and solid pattern. But the problem is 22% of these core biopsies, they become non-diagnostic. And if radiologically suspicious, we have to go for a repeat biopsy. And most of the time with the repeat biopsy, we could get a diagnostic yield. And general recommended is 2 cores, and we have to take it from the peripheral zone and the non-necrotic areas. If the tumor is quite large in size, even we can go for 4 cores. Complication and tumor seeding is very uncommon. So it's a relatively safe procedure. So when we come to small renal mass, the treatment options available to us is we can go for a surgical treatment, partial nephrectomy or radical nephrectomy. Radical nephrectomy generally for very highly malignant features like sarcomatous features are there. We can consider radical nephrectomy. Certain researchers believe for highly aggressive small renal masses, better to go for radical nephrectomy for better survival. And these surgical methods can be carried out open laparoscopically or robotic assisted. Another way of managing is ablation, cryoablation and radiofrequency ablation. And other ways of doing is active surveillance and watchful waiting. We consider surgical treatment. There is a partial nephrectomy. There are different researchers have produced different results. there is a core-specific survival almost comparable with partial nephrectomy and radical nephrectomy. Some researchers are even telling radical nephrectomy is better. So there are some controversies in that. But generally, urological associations are recommending to go for partial nephrectomy. That is the gold standard. They have proved that in a younger population, partial nephrectomy definitely gives a better overall survival is there. And even considering older people, elderly also, surgery gives a better overall survival than non-surgical management unless the patient is, has multiple comorbidities and is frail. Adenectomy is not generally routinely recommended during surgical procedures unless it's clinically evident that it's involved. Lymph node dissection also, there is a controversy whether it produces significant survival benefit. Different researchers have different views on that. And if a patient is unfit and it's unresectable, like hilar tumors, and patient is symptomatic with hematuria or flank pain, we can go for embolization, which is not commonly found in small renal masses, usually for larger tumors. So surgical treatment, if you consider laparoscopy versus open, radical nephrectomy, laparoscopy has a shorter hospital stay, has a lower analgesic requirement, shorter recovery period. So generally better, more preferred. In partial nephrectomy, laparoscopy has a longer operative time, less blood loss, but warm ischemia time is longer in the laparoscopy method. And ablation,
so Achyutan,
yes.
So doing the partial nephrectomy by laparoscopic or robotic is more technically easier?
Robotic is more easy.
So what is the advantage over the laparoscopic in regards to the warm ischemia time? Yes, isn't it? That's only advantage between the laparoscopy and robotic. The warm ischemia time is less with the robotic surgery.
Yeah, just to add that, Achyutan, so what do you think is the usual warm ischemia time which is allowed for a partial nephrectomy?
We can go up 25 minutes. 20 minutes.
Yeah,
we can
acute tubular necrosis patterns are seen after 20 to 25 minutes. So warm ischemia time is 20 to 25 minutes. What about the cold ischemia time? You can go up to about 60 minutes if you are going to cool down the kidney. So if you are putting an ice slush, and if you put an ice slush or cold saline for 10 minutes, but you have to wait for 10 minutes, then you can improve your cold ischemia time up to about 45 to 50 minutes. Some people say 1 hour. So it is best adapted in multiple, like in VHL, where there you have to do a couple of more partial nephrectomies in the same kidney, or in a complex case where there is a hilar involvement and more central tumors, which you have to spend some more time for resection. So that is about the warm and cold ischemia times.
Yes. So when we consider ablation, it's ideal for all the patients with small renal masses of the RCC type who are unfit for surgery, but they are not candidates for active surveillance also. So then in that situation, we consider ablation. There are different modes of ablation. Radiofrequency ablation has been studied well. Both cryoablation, radiofrequency ablation can be done laparoscopic assisted or percutaneous. Whichever method, both they have the same, either percutaneous or laparoscopy, both they have the same survival benefit. There is no much difference, but the recovery and follow-up is much easier with percutaneous method. And if you consider cryoablation, it has certain benefits over radiofrequency, where you can have real-time image of the ice ball we are using for the cryoablation, and we can use multiple probes simultaneously to extend the treatment area volume, and also there's a uniformity of the ablation zone. There are other ablative techniques which are used now only for experimentation, such as microwave, laser, and high-intensity focus ultrasound. There are researchers, some researchers which compare radiofrequency ablation to nephrectomy. They're actually saying that it gives a better, less complications and also less decline in renal function compared to the nephrectomy in the radiofrequency ablation.
Yeah, actually. So what's the basic difference between RFA and cryo? Which one is hot? Which one is cold?
Cold is cryo. Radio frequencies.
So we are killing the cancer cell with cold is a cryo, with the thermal energy is RFA. But if you ask the expert, they will say, which one is better, sir? Is it RFA or cryo, in your opinion, have a better effect on tumor management?
I think personally, I don't have any experience in cryo, but I think using heat, the problem is that is deciding on the extent of the tumor destruction. So the cryo, when you use cryo, actually the margins can be very clearly defined. So you will see the ice ball forming and then destroying the thing. I'm not quite sure which is better when it comes to cell destruction, because both use extreme heat and cold. You have any idea, Balgo?
But literature says the positive surgical margin is less with cryo than the RFA, but the complications are less with RFA than the cryo.
Yeah, that may be true. I think definitely the positive margin, if you take the cryo ball, you can see the ice ball forming, and then you can, with the intraoperative ultrasound, if you're doing laparoscopically, you can define the margins. Why cryo complications are more, I'm not quite sure. You have any idea?
I think, sir, most of the time this is need some sort of anesthesia, laparoscopy, and so maybe that may be the reason. Because most of the RFAs are done locally and percutaneously.
Yeah.
Okay, actually, you can.
Just ordinary, just a question, practical question. Can we use laparoscopically or open surgery? Can we use just diathermy?
I think Anuruddha sir is the best person to answer, because in his practice, I have seen he's doing extensive sort of ablations with the diathermy, the tumor base.
We have RFA, Nishant. Sir, we have RFA, which they do, radiologists do percutaneously.
Yeah.
So but I think we don't have cryo, sir.
Yeah. RFA and diathermy, we are trying to compare. It's not in the guidelines, and it will never come into the guidelines. But if you're doing a VHL case, we did one very recently also, multiple tumors, so small tumors. If you don't have the RFA probe, then they are open surgery, you can just use the diathermy.
Yes. Same effect, yes.
That's diathermy is a RFA in a bigger way.
So,
right.
Okay, actually.
Yeah. So when we consider active surveillance we can use for all the comorbid patients because before the cancer causes death in the patient, the patient has multiple other competing comorbidities which can cause death in a much earlier time. So there is no point in going for a surgical management in that patient. Like I previously mentioned, you have to do serial abdominal imaging to monitor the tumor size. Up to 1 centimeter, there is need for tumor biopsy. After 1 centimeter, you can consider renal tumor biopsy. So usually the follow-up goes as first after 3 months after diagnosis, you do ultrasound, then OCT, any imaging. Then after another 6 months, you repeat it. Then there is stability of the tumor, no growth, significant growth of the tumor. You can do it for 6 monthly up to 3 years, and then annually thereafter. So if there is any indication for biopsy, such as doubling in size within 1 year, or tumor growth more than 4 centimeters in size, you can go for a biopsy, or you can even consider re-biopsy. It has been proven in those sort of patients, there is no significant difference in overall survival.
More than doubling time, as Dr. Nishant said, the tumor growth rate more than 5 millimeter per year is an indicator of more active intervention. So I think the more than 5 millimeter per year.
Yeah, I think there is a historical study which is done by I can't remember the name. So in that series, what they have looked into is the kind of follow-up of a retrospective series where they have followed up all these patients like in an active surveillance way, and then ultimately they all went for the surgery. So you look at the data, median tumor growth rate, if you analyze per year, in a more sort of a benign or low-grade tumors, it is around 0.3 millimeter per year. So we can say roughly about less than 0.5 millimeter per year is more towards benign disease. And median tumor size increment in malignant tumors or high-grade disease is around 0.9 per year, 0.9 millimeter. So if something is around 1 centimeter per year, that is highly suggestive of a sort of advanced or aggressive disease. So which has to be dealt with some sort of a surgery or ablative method. Yeah, carry on.
And in virtual waiting, these patients, their comorbidities, with that we could not do any active treatment. So the difference between this and active surveillance is that we are not doing serial ultrasound imaging. We only do it when there is a clear-cut clinical indication to do it. That is the difference between active surveillance and virtual waiting. If you consider ablative treatment versus partial nephrectomy, so different results have shown different results, but generally considering both cryo and radiofrequency ablation, partial nephrectomy shows a better benefit in overall survival and cancer-specific survival. Perioperative outcomes and complication rates and quality of life after the surgery, there's a mixed results are produced between the ablative techniques and the partial nephrectomy. Metastasis-free survival also is superior after partial nephrectomy and cryoablation compared to the RFA. So RFA is the least preferred one in these methods. Partial nephrectomy and scoring systems, this I think we have already discussed during the first presentation. So we have different classification systems to decide on partial nephrectomy, the Padua score, the renal nephrometry score, C index, arterial-based complexity scoring system, and the zonal nephro scoring system. Like Balagobis has mentioned, there is not much difference between Padua classification and the nephrometry score. They are very similar, which considers the size of the tumor, whether it's exophytic or endophytic, and whether it's close to the collecting system and the polar lines. If you consider C index, that's a centrality index, which gives a numerical score based on the combination of the tumor, diameter of the tumor and the distance of the tumor edge from the center of the kidney. There's another one called arterial-based complexity scoring system, which correlates the renal tumor with the arterial vasculature of the tumor. Zonal nephro scoring system subdivides each of these different criteria into zones, nearness to the collecting system, physical zone, radius and the organization into different zones, zone 1, 2, 3, and based on that gives a risk stratification. And complications, common complications after partial nephrectomy and their management. So you can have urinary leak and fistula. This usually presents after 1 or 2 weeks after surgery. If the drain is kept for 7 to 10 days, when we have a suspicion, we will be able to detect it. But if the drain has been removed early, then we have a suspicion, we have to go for an intravenous pyelogram or a retrograde pyelogram. And treatment usually will not require a exploration or resurgery. We will able to be controlled with a double J stent and a perinephric drain and a Foley catheter to keep a low pressure system. And post-operative bleeding, so we like any bleeding patient, we have bed rest, hydration, and monitor the hemoglobin levels. Also monitor the patient, and if there's significant blood dropping hemoglobin and blood transfusion is required in the patient, we might consider referring to the intervention radiologist for a radiological angioembolization. If it's life-threatening, we might consider nephrectomy or go for complete renal angio infarction. Renal insufficiency is not very common, but can occur in solitary kidneys. But usually, this is a transient acute kidney injury due to transient obstruction or thrombosis, or maybe due to certain drugs. So this usually can be managed with a hemodialysis, and will self-settle with the management. And after we go for a
what kind of margin we should have? What about doing an enucleation of the tumor? Is it okay?
Yeah, enucleation can be also considered, yes.
So is there different, what sort of margin we should have? 1 millimeter, 1 cell line, 5 millimeter, 1 centimeter?
1 millimeter.
Partial nephrectomy.
2 millimeters would be enough.
We ask from the experts.
Yeah, I think enucleation is a very well sort of accepted and standard technique, because especially when it comes to VHL and multiple tumors, so that the argument was sometimes back there was a paper to with a comparative study to find out whether enucleation and tumor-based diathermy is necessary. So the comparison was between enucleation, pure enucleation, and enucleation plus tumor-based diathermy. And what they have shown is that there is no difference in that either. So this pseudopodia and pseudocapsule and those things are very theoretical. So enucleation is quite a possible thing. So, but anyway, to get rid of the anxiety, I think then Balagaba was mentioning about the one cell layer clearance. And pathologists are not very happy with that anyway. They can't find one cell layer there. So I think keeping even a 1 millimeter margin with some healthy, macroscopically healthy tumor, the kidney tissue, I think should prevent local recurrence. What do you think, Anuruddha and Balagaba? Nishant?
I think this comes. This is really a practical situation when you do a laparoscopic partial nephrectomy. So because most of the time we don't have this tactile sensation, even in the robotic. This is one of the problems. So what they use is they use two techniques. One I have seen. One is actually the intraoperative ultrasonography, where you introduce a small sort of wired probe to one of the ports, and you can easily sort of see where the deep margins are, and you can have some sort of a three-dimensional image in your head when you are performing the surgery. So that is one way. And the other thing is quite a novel thing. I haven't seen it, but I have seen the demonstrations. It's called a firefly technique. Yeah. So where you inject some sort of a radioluminescence. That's right. Yeah. And then exactly. Then you can see very nicely the tumor. You take up the thing, and then when you sort of darken the area or switch off all these, and then you can see it through some sort of a radioluminescence viewer. You can see the extent. But I quite agree with you, sir. I mean, even the enucleation. I mean, we have done a couple of cases when I was a trainee with you. So I mean, most of these people, they never had a positive margin. So.
Yeah, and the firefly technique, just to elaborate on that a little bit, I mean, it's very quite popular. When you're doing partial nephrectomies, what you do is you do a little bit of hilar dissection, and you tie the segmental artery. You just put a bulldog into the segmental artery, and then give the dye which sort of shines green, and then you will see the margin, exact margin where to cut make the incision. So if it is beyond the tumor, actually the tumor area will be actually dark, and the normal kidney will be green. Okay. So you get the exact margin to separate the normal part from the. But for that you have to clamp the segmental artery, and yes, I think. Anuruddha, what is your idea about enucleation? You have done it?
I think enucleation is adequate. So as you said, the only issue is if the histology has some poor prognostic features like sarcomatoid or rhabdoid differentiation.
Yes.
Then what they have found is local recurrences are possible and higher.
Yes.
That is the only issue.
Yeah. Then of course you have to go ahead with that is nephrectomy.
That's right.
If they're especially sarcomatoid,
right. And that is one of the advantages doing a pre-biopsy.
That's right. Yes.
I mean, doing a biopsy. So now that the biopsy is coming in quite a sort of aggressive way. So,
because there are sort of poor prognostic features, then of course you will keep a better margin, or you think it's going ahead with a radical nephrectomy.
Yes.
You can continue.
So in management of when we get positive margin, especially because the gold standard is partial nephrectomy, 2 to 8% has been shown to become margin positive. But this does not produce, this is very, very common in stage 3, stage 4 tumors. And this doesn't come to solitary tumors, but commonly for RCC for stage 3 and stage 4 cancers. And when you have a solitary kidney and bilateral tumors, we are more worried about preserving kidney. So there's a higher chance to have a margin positive. Yeah, but this does not increase any further risk of metastasis or affect the cancer-specific, core-specific survival. But there is a higher chance of local tumor that recurrence, 16% versus 3% in a negative margin. Usually, radical nephrectomy or resection of the margins is an over-treatment. So, but those patients will need intense surveillance, and we might consider local therapies, but very rarely we will need a resection or a radical nephrectomy in these patients. Thank you.
Just one point. Why do you sort of call it an overtreatment, treating a positive margin?
Because it does not affect his survival. We are getting the patient through another surgical procedure.
Yeah, because you just mentioned that only even if the margins are negative, 3% will get the local recurrence, and also only 30% will develop local recurrence even if the macroscopic margins are positive, or microscopic margins are positive. So in which case about 60% will be all right, isn't it? So you need a sort of very close, keep a close eye on it.
Yes.
And yeah, thank you very much. And it was a very good presentation and comprehensive presentation. Just wanted to highlight for the benefit of the trainees, just wanted to highlight a few things about the biopsy, I thought. Just quickly go through. So if you look at the, can you see my screen? So can you see my screen?
Yes, Nishant, I can see nicely.
All right, okay. So you can see for the benefit of the trainees, so you can see there is what is called there's a question about seeding actually. So whether there is any positive sort of negative impact on biopsy on seeding. So you can see most of the time now the people who are doing biopsies are adopting what is called a coaxial biopsy needle. So the axial sheath will go to the tumor and only the biopsy needle will come out at the edge of the tumor. So that track seeding is prevented. So that is one of the points that we need to highlight. Second thing is the what is the wider, why would you use widely renal biopsies these days? Because none of these series have shown significant risk factors, and none of these series shows significant seeding during the their follow-up period. So that is one of the important things in biopsy. Third important thing which I wanted to highlight is, of course, we all know the indications for the biopsy, ablative, before the ablative therapy, or when you wanted to give systemic therapy for cancer or the metastatic cancer, or when you want to do active surveillance. Those are the three indications. But again, one of the most important thing is to find out when you are going to do a biopsy, whether it is going to sort of make your management different. Unless it's going to change your management, the guidance is not to do a biopsy. So always, even though we talk about all those indications, we have to always think about that particular clinical scenario and see whether when you get the histology, will it going to change? For example, you get an elderly gentleman who is about 8 years of old, and you don't have to biopsy that in the watchful waiting. So if it is not going to change, for example, you get a young gentleman, some sort of a radiologically indeterminate lesion, but it is suspicious of most probably a tumor. So then you don't need to do a biopsy unless a specific condition that we mentioned, that something like, a very highly aggressive disease or a metastasis or something. So otherwise, we don't have to do a biopsy. We can either go for a primary treatment like partial nephrectomy, that it will be the same as the biopsy. So it is same in the AUA guidelines. Again, one of the things that we need to highlight is only if the management is going to be changed, do a biopsy. But there are certain other sort of situations where biopsy may be helpful. For example, if you take a marginally renally impaired patient with a large RCC, when you want to decide to go for a radical nephrectomy or a partial nephrectomy, now if you know that this is a low-grade tumor, you can always do a radical nephrectomy. But if you know, partial nephrectomy. But if it is a high-grade tumor, you're not going to take that chance, and you're going to straight away go for a radical nephrectomy. The same thing is true for a young patient. For example, in this case, you can see there's a large tumor, and as Professor Nevkara mentioned, if you really think of getting the maximum out and leaving the maximum of the renal tissue there, if you want to decide that, you can always, there is a place for biopsy if it is especially a young patient, right? Because you will be in real pinch if you leave some sort of a tissue, and if you do a partial nephrectomy for a highly aggressive disease or slightly more aggressive disease, you will be putting the patient into unnecessary follow-up with a high dose of radiation in the follow-up period. So these are some of the important things which I came across for the importance of trainees benefit. I just wanted to highlight. Thank you. We can go for the next one.
So, we are inviting Dr. Niroshan to talk about the management of localized RCC. Then at the end of the session, we will discuss about we'll get the opinion from the experts. Niroshan, over to you.
Yes, sir, thank you.
Yes, Niroshan, go ahead.
Thank you, sir. I'm going to present with regarding the management of localized renal cell carcinoma, and this would be the outline of my presentation. And I'm going to discuss about the imperative and relative indications for the partial nephrectomy. Radical nephrectomy versus partial nephrectomy, basically what are the comparison and the summary of evidence available, and whether we should perform the lymph node dissection or not, and when to do the adrenalectomy, as well as the surgical techniques when it comes to radical nephrectomy. What are the evidence-based proven practices, and the recommended follow-up after the surgery. So this historically, the surgery has been the benchmark for the treatment of localized renal cell carcinoma, and the surgical options are broadly categorized into radical versus partial nephrectomy, and the surgical techniques are open versus laparoscopy and the robotic nephrectomy. And when it comes to the indications for partial nephrectomy, there are imperative indications as well as relative indications. And imperative indications are when the patient would be basically anephric, anatomically or functionally anephric, if the radical nephrectomy was performed. In those situations, it is indicated to go for partial nephrectomy, such as when the tumors are occupying both kidneys, and when there's a tumor occupying the solitary functioning kidney, and also when there's a RCC in a patient who's having pre-existing severe renal impairment of the contralateral kidney. And these are the imperative indications, and the relative indications include again when the either there's a mild impairment of the renal function, as well as when there's a increased risk of renal impairment in the future, and also it is well known that partial nephrectomy is the treatment of choice for T1A tumors. It was the previous belief, but now it is even indicated for T1B as well as T2 tumors, provided the contraindications for the partial nephrectomy is not there. So we should not consider partial nephrectomy in locally advanced tumors, and also when the tumor is located in unfavorable locations, such as in the hilar region, and if this renal score or the Padua score is pointing towards high risk, if we are going for the partial nephrectomy. In these situations, we can actually go for the radical nephrectomy instead of partial nephrectomy. And when it comes to the evidence with regard to radical nephrectomy and partial nephrectomy, the oncological comparison has actually there are actually less studies comparing the oncological outcomes, and because randomized studies are rare, in a prospective randomized control trial, which includes organ confined renal cell carcinoma, which are less than 5 centimeters, has shown the cancer specific survival is comparable when it comes to the partial nephrectomy as well as versus radical nephrectomy. And also in this study, it has shown partial nephrectomy demonstrated to preserve the kidney functions better after the surgery, thereby potentially lowering the risk of development of cardiovascular disorder. And there were several retrospective analyses, and which has suggested again the same fact that there's a decreased cardiovascular specific mortality as well as improved overall survival for the partial nephrectomy when compared to the radical nephrectomy. However, in some series, they have found this fact is only true when we operate on a younger patient, because when the comorbidities are applied into the picture, sometimes during the time of surgical intervention, if the patient is having significant comorbidities, sometimes this mortality benefit might not be actually seen when that correction has been applied. And also a Cochrane review found that partial nephrectomy for clinically localized renal cell carcinoma was associated with reduced time to death of any cause compared to the radical nephrectomy. And also the serious side event rates, cancer specific survival, and time to recurrence were similar between the two groups. And also they have also compared the surgical management with the non-surgical management when it comes to the elderly people, because they are the ones who are carrying a lot of comorbidities. And in one database analysis, that is Medicare database analysis, it has shown actually there's no significant overall survival benefit when it comes to a patient who's more than 75 years of age. So we can manage the patient non-surgically. But there was another study which addressed the same question, and during that study they have included this Medicare database patient as well, and there they have found there's an overall survival benefit in older renal cell carcinoma patient population, especially when they are 75 to 80 years of age, when subjected to surgery rather than managing them non-surgically. So and also the quality of life was ranked higher following partial nephrectomy when compared to the radical nephrectomy. But in general, patient's health status will deteriorate following both approaches, whether it is partial nephrectomy or radical nephrectomy, but the deterioration is less when it comes to the partial nephrectomy. And also in patients with pre-existing CKD, partial nephrectomy has proven to be the preferred surgical treatment option, because it has reduced the deterioration of the existing kidney dysfunction. And also, the study has compared the survival outcome in patients with larger clear cell renal cell carcinoma, more than 7 centimeters, treated with partial nephrectomy versus radical nephrectomy with long-term follow-up. And compared to the radical nephrectomy group, the partial nephrectomy group had a significantly longer median overall survival and median cancer specific survival. And also in a systemic review and in meta-analysis also, it has studied T1B and T2 renal cell cancers, and which are treated with partial nephrectomy versus radical nephrectomy, and it has shown that partial nephrectomy group had a lower likelihood of tumor recurrence, cancer-specific mortality, and all-cause mortality compared to the radical nephrectomy group. But again, in the same study, the T2 tumors, when treated with partial nephrectomy, they suffered estimated higher blood loss, and also likelihood of complications were also higher when we are doing partial nephrectomy for a patient with T2 tumor, that is a kind of a large tumor. Then if I summarize the evidence that I presented, the oncological outcomes in terms of overall survival following partial nephrectomy actually equals that of radical nephrectomy in patients with T1 renal cell cancer. Because of that, the European Urological Association recommends to offer surgery to achieve cure in localized renal cell cancer, and also they recommends to offer partial nephrectomy to the patients with T1 tumor, despite whether it is T1A or T1B. And then when to do, and yeah.
So if you are getting a 70-year-old ASA1 patient with a T1B tumor at the lower pole, that is exophytic growth. 70-year-old ASA1 T1B at lower pole exophytic. So what are you going to do?
So then it's a SA1 tumor, and as the according to the evidence, still the surgery would be the option. So then the decision would be whether it is partial nephrectomy or radical nephrectomy, and so it's T1B tumor. If it is more than 7 centimeters, the risk of bleeding and complications are higher in this patient, and also he is a 75 with reduced life expectancy. In that scenario, I would consider going for a radical nephrectomy rather than going for a partial nephrectomy in this patient, though it's a exophytic tumor.
I think the experts will agree or disagree. I of course agree with you.
What about the patient's serum creatinine and the status of proteinuria and other?
All good. ASA1.
Yeah, I think if it is ASA1, quite agree.
Okay, Roshan, proceed.
What about the expert opinion, Neville sir?
Neville sir and Anand sir?
If difficult decision, Gobi, I would give the option to the patient, because it's very difficult. No, radical should be the thing, but even partial, we haven't had that many complications. So we do the retroperitoneal approach for partial, and very fast recovery also, and therefore we can do a partial even in that scenario. I don't know, it's not evidence based, but to me there is not much of a difference.
Most of the papers are saying there's a cardiovascular mobility is more with CKD. Is it a medical CKD or surgically made CKD? Both are same?
Very difficult to say, Balagobi. You know, actually, although they get this CKD, whether it's really clinically significant is the issue. They may have a little bit of a high serum creatinine level. That is why I think Niroshan said that they are having high cardiovascular morbidity rather than morbidity directly related to CKD. So we don't have figures for our series, but although there could be a subtle rise in serum creatinine, it doesn't really reach that high to require renal replacement therapy as such, but that subtle rise can cause cardiovascular morbidity, of course. Therefore, it's a difficult decision. I mean, I totally agree. A radical would be quite okay.
Niroshan,
yeah, if you look at the AU guidelines,
yes,
if you look at the AUA guidelines, it always says a physician should consider radical nephrectomy only if there is a high tumor complexity or pre-existing CKD, or if the EGFR or contractile kidney with if there's normal contractile kidney. So
yeah.
there is, I mean, they always recommend to go for a partial nephrectomy
Yes.
unless these factors are there.
Yeah. So
So you are quite
A170, I
right
would
in
do a
that.
partial, but I would do the sort of posterolateral approach, retroperitoneal, because we do open.
Niroshan, after nephrectomy, the EGFR, they slowly they come to the normal. What's the physiology behind it?
I think the contralateral kidney undergo hyperplasia, and then it will actually take over the rest of the kidney's function.
Yeah, one is hypertrophy. Other one is, they say, hyperfiltration, more glomerular filtration. But that can have a negative effect. Sometimes they develop glomerulosclerosis because of the hyperfiltration. So some people, renal function get worse with the time because of the hyperfiltration. But some people, EGFR improve because of the hyperfiltration. Okay, Roshan.
Yeah. Can you all hear me? Yeah. Can you all hear me?
Yes, sir. Yes, sir.
Yes, sir.
Yeah, I think I tend to agree with that that hypothetical case. I tend to agree with Anuruddha. I also would go for a partial, because one thing, that longevity is something very subjective. If this 72-year-old man is going to live up to 92, I think he will need that preserved kidney for his renal function in the long term. And then again, going for, I would think of, I will go for the EGFR or the creatinine clearance. And there is a cutoff line described in some of these meta-analyses as 60. When it comes to 60, or if it is above 60, the outcome, the long-term outcome of this outcome of partial and radical nephrectomy, the margin becomes thinner. So, but if it is closer to 60 or just below 60, then of course you must try your best to preserve as much nephrones as possible. So if it's a fit 70-year-old man, we always nowadays we go for retroperitoneal approach, because the outcome of the postoperative outcome is much better than transgressing the peritoneum. So I would agree with Anuruddha in doing a partial nephrectomy follow-up. But consider this cutoff line of 60 is given in some of these meta-analyses.
Proceed.
Okay. So then next I would discuss when to do the adrenalectomy. And there's one prospective non-randomized study which has compared the outcome of radical nephrectomy while doing the ipsilateral adrenalectomy and without doing the ipsilateral adrenalectomy. And they have actually justified the adrenalectomy basically depending on the radiographic and intraoperative findings. And there were 2,065 patients who underwent surgery, but only 48 out of that has undergone the ipsilateral adrenalectomy. And from that also, only 42 patients, the 42 patients were found to have benign lesions. And also they have analyzed and showed that upper pole location was not predictive of adrenal involvement anymore, because previously there was a belief that if the tumor is located in the upper pole, there's a higher chance of involvement of the adrenal gland. But now it is no longer there. Instead of that, it is suggested that tumor size is sometimes correlated with the risk of involvement of the adrenal gland. And also, they have found there's no difference in overall survival at 5 years or 10 years, though you do the adrenalectomy or not. And so according to the evidence, ipsilateral adrenalectomy during radical nephrectomy or partial nephrectomy has no survival advantage in the absence of clinically evident adrenal involvement. That's one. And also, EAU recommends not to perform ipsilateral adrenalectomy if there is no clinical evidence of invasion of the adrenal gland. And next, about should we perform lymph node dissection or not, and clinical assessment of the lymph node status.
Yeah, can I interrupt you for a second? Now you said the last sentence there that if there is no clinical indication, isn't it? Not radiological indication. So that gives us a.
So actually, the guideline says radiological also.
Yeah, but on the other hand, it says that clinically, if it is involved and it's almost inseparable from the upper polar tumor, whatever the CT says, it may be safer to get rid of it. So some of the guidelines say that. So take a per-operative decision as well. We go by the CT, but if it's a larger tumor and with clinical evidence of adrenal stretching over that, sometimes you might have to get rid of that. And I don't think anybody will find fault with you. Okay, please.
Okay. So the clinical assessment of the lymph node status is based on the detection of enlarged lymph nodes either by CT or MRI or during as an intraoperative finding. And also there's actually less than 20% of suspected metastatic lymph nodes are actually positive for metastatic disease when you go with the histopathological examination findings. And also both the CT as well as MRI are unsuitable for the detection of malignant deposits in the lymph nodes if they are normal in shape and size, because micromets in the lymph nodes cannot be detected by these investigations. And in a large retrospective study, the outcomes of the radical nephrectomy with or without lymph node dissection in patients with high risk localized renal cell cancers were compared. And in this study, they have found lymph node dissection was not significantly associated with reduced risk of distant metastasis or cancer-specific or all-cause mortality. But they have found the number of lymph node metastases, whether it is less than 4 or more than 4, as well as the extracapsular extension of extracapsular extension is there or not correlates with the clinical prognosis of the patient. And also there's a better survival outcome when there's less number of positive lymph node, that is less than 4, and also there's no extranodal extension was found. And there's another study which demonstrated that extended lymph node dissection results in significant prolongation of cancer-specific survival in patients with unfavorable prognostic features. Not in all patients, but the patients who are having renal cell cancer, but in pathological examination, it has found it's a sarcomatoid differentiation. And also if when there's a large tumor size in these high-risk patients, there's a cancer-specific survival benefit in performing extended lymph node dissection. And as to the, they have also studied with regard to the morbidity related to this extended lymph node dissection, and it has shown this lymph node dissection has not associated with increased risk of Cleveland-Dindo classification more than 3 complications, and also it is not associated with either increased length of hospital stay or increased estimated increased blood loss. So basically, this extended lymph node dissection has to be is shown to be comparatively a safer procedure without causing any significant increment in post-operative complications. And there was a one randomized control study evaluating the clinical value of lymph node dissection combined with the surgical treatment of the primary renal cell cancer. And there they show the risk of lymphatic spread appears to be very low, with the incidence of only 4%. And so because of this fact, they have attributed only a staging effect for this lymph node dissection. But there were some problems or deficits with regard to this study, because one thing is they actually included very high number of T2 tumors, patients with T2 tumors, where there's no actual increase in risk of lymph node metastasis, and also only 25% of patients were there with T3 tumors in this study, and the lymph node template that they use for the lymph node dissection has also not been clearly stated in that study. So those are the deficits in this study. And also about the optimal extent of the lymph node dissection, it is also a controversial topic. And according to the retrospective studies, they suggest the lymph node dissection should involve the lymph nodes around the ipsilateral great vessel, and also the inter-aortocaval region from the crus of the diaphragm to the common iliac artery, because they have found the involvement of the inter-aortocaval lymph node in 35 to 45% of the cases where the hilar lymph nodes are negative. So there can be kind of a skip involvement of the lymph nodes when it comes to the renal cell cancer. And they have recommended at least 15 lymph nodes should be removed to get a better pathological report. And the summary, as a summary of these evidence, in patients with localized disease without clinical evidence of lymph node metastasis, a survival advantage of lymph node dissection in conjunction with radical nephrectomy is not demonstrated in randomized control trials. And retrospective studies suggest that there's a clinical benefit which is associated with lymphadenectomy in high-risk patients such as large tumors and these sarcomatoid changes. So depending on these evidence, the EAU advised to offer an extended lymph node dissection to patients with adverse clinical features such as large diameter of primary tumor as a weak recommendation. And also they advised to offer lymph node dissection in patients with clinically enlarged lymph nodes for staging purposes or local control. Then about, yes. Yes.
Time is, you have 1 more minute. So we can finish quick.
Okay. About the radical nephrectomy versus tactical nephrectomy techniques, whether to go for the open versus laparoscopic technique. And actually in studies, they have found less morbidity was found for the laparoscopic compared to the open radical nephrectomy. But actually there's no difference in number of patients receiving number of blood transfusion, perioperative blood loss, and there were in certain studies the number of perioperative blood transfusions and also the perioperative blood loss was significantly less in laparoscopic surgery. But postoperative quality of life was similar when compared to the open versus laparoscopic nephrectomy. And quality of life, as I told, variables were similar in both approaches. Whether it is retroperitoneal or transperitoneal doesn't matter. And when it comes to the hand-assisted approach, the duration of surgery was significantly shorter in hand-assisted approach when compared to the laparoscopic standard laparoscopic surgery. So the recommendation is EAU recommends to offer laparoscopic radical nephrectomy to patients with T2 tumors and localized masses not treatable by partial nephrectomy. And with regard to this follow-up after surgery, actually the prognosis of the renal cell cancer depending on certain prognostic features. Actually, if it is a localized renal cell cancer with low risk, the outcome would be excellent. Because of that, it is unjustifiable to follow up all the patient in similar manner. Because of that, follow-up is recommended depending on the risk stratification, such as high risk, intermediate, and low risk patients. And generally, the surveillance or the follow-up measures include these investigations. And also, there's an important point that there's no evidence to say that early versus later diagnosis of recurrences will improve the survival outcome. But since these high risk, low risk, and intermediate risk categories are there, now EAU proposed several surveillance schedules depending on the risk profile of the patient. Like this. So low risk patients, as you can see, are reviewed less frequently with less sensitive investigations. And when it comes to the high risk and intermediate risk group, the surveillance frequency and the duration of the type of investigation that we use changes. And the ideal duration of the follow-up, there's again controversy, and generally some argue that follow-up with imaging after 5 years is not cost effective, but certain studies indicates it has to be followed up to 10 years. So that concludes my presentation. Thank you.
Yeah, thank you, Niroshan. We will move to the next presentation, and then we can take the questions from the trainees and experts. Next one is
just a quick question from Niroshan. How do you categorize the risk stratification? What are the methods that you use?
So there are actually there are different risk stratification system. There are some of them are validated.
What is the one which you use commonly?
They use this Los Angeles, California criteria one, and also this the one that I showed you. And these include actually the age, pathological stage, the stage of the disease, and the grade, Ferman grading, and the WHO grading, and also the patient's comorbidities also included in certain risk stratification systems, and they have actually created nomograms. So depending on these, they actually stratified these high risk, low risk, and intermediate risk groups.
Yeah, the one common which we use is the Lebovic score. And Lebovic score, you use the TNM stage as well as the Ferman grade. So that is why it is quite important for all the trainees to go through what is Lebovic score and what are the components of it, and then to know what are the Ferman grades. And whenever you get a patient, try to categorize your patient's risk category according to the Lebovic score, because this is what we see in mainly when you go to another country, especially when you follow up the EU guidelines, they go for the Lebovic score, and that's how you categorize the risk group, and that's how you recommend the follow-up according to the Lebovic score. Thank you. Yeah, the next speaker can start.
Time permits, after the Nalin's presentation, I will show you the slide of Lebovic score. Yeah, Nalin, you can start.
Yeah.
Good afternoon, and I'm Nalin Palhipitis in Registrar Urology at NHSL. I'll be discussing about management of advanced renal cell cancers. And my outline would be, I'll be discussing about basics of metastatic renal cell cancers, locally advanced renal cancers, and tumor thrombectomy, and prognostic, about a few words about prognostic models and role of cytoreductive nephrectomy in metastatic renal cell cancers, and role of metastatectomy and systemic therapy. So basically, advanced renal cell cancers can be divided into locally advanced renal cell cancers and metastatic renal cancers. Locally advanced RCC has been already discussed, and I'll be mainly focusing on metastatic renal cell cancers. So locally advanced are further divided into lymph node metastasis and tumor thrombus. Lymph node metastasis has already been discussed, but I'll be touching upon the tumor thrombus in locally advanced disease. And commonly occurring distant metastases are occurring into the lung, brain, pancreas, and bones and liver. So lymph node metastasis already has been discussed. So I'll be mainly focusing on renal cell cancers which are having venous tumor thrombi. Having a venous tumor thrombi itself is an adverse prognostic factor, but unfortunately, the available data are derived only from case series. There are no randomized controlled trials with regards to tumor thrombi and metastatic renal cell cancers. So therefore, all the evidences available in the EUA guidelines as well as AUA guidelines are based on case series. But according to these case series, the level of tumor thrombus, whether it goes beyond the diaphragm or whether it stays below the diaphragm, is not associated with any other prognostic factors like tumor dissemination into lymph nodes or perinephric factor distant metastasis. So based on this little bit of evidence, the EUA recommends that irrespective of the extent of the tumor thrombus at the time of presentation, all patients with renal tumor thrombi should be offered surgery. And the form of surgery, whether it's thoracotomy approach or whether it's true laparotomy approach, depends on the surgeon's discretion. So I'm moving on to the second part, that is prognostic models used in metastatic renal cell cancers. I'll be comparing prognostic models that are being used to prognosticate localized renal cell cancers as well as metastatic renal cell cancers. As you see in this summary table, you will see that metastatic renal cell cancers prognostic models are more concentrating on systemic effects of renal cell cancers. So therefore, the prognostic model includes few prognostic indicators like biochemical as well as hematological indicators. Whereas in localized renal cell cancers, only the patient's performance status as well as histopathological grading is used as prognostic indicators. But if you see, in both categories, patient's performance status is being taken into consideration. However, in my topic, I'll be mainly focusing on metastatic renal cell cancers. So therefore, the most commonly used prognostic model and which is also used in EUA guideline is the IMDC or International Metastatic Renal Cancer Database Consortium risk model, which has about 8 prognostic indicators. And if a patient is having more than 3 prognostic indicators positive, those patients are being considered as high risk metastatic renal cell cancers. And in such patients with metastatic renal cell cancers, the role of cytoreductive nephrectomy is discussed for a long time. But however, up to date, the evidence available are based on many randomized control trials. Out of them, one of the famous randomized control trial is the Carmina 3 trial, a phase 3 trial, which has investigated the impact of immediate cytoreductive nephrectomy followed by sunitinib versus sunitinib alone. However, this has shown that the cytoreductive nephrectomy plus sunitinib is not superior than giving sunitinib alone. So therefore, there was no overall survival benefit with regards to doing a cytoreductive nephrectomy if you are offering patient targeted therapy as well. Similar findings were found in certain study as well, which had studied whether doing cytoreductive nephrectomy before giving sunitinib is superior to giving sunitinib and then defer surgery. But this has also shown that there's no difference in the two groups with regards to progression-free survival. So therefore, based on these evidences, in patients with poor performance status and small primaries with high metastatic volume, the EUA does not recommend cytoreductive nephrectomy according to the current evidence base. But in patients with a good performance status, who do not require systemic therapy following cytoreductive nephrectomy, if we can predict it, and patients who are having no or oligometastasis, then cytoreductive nephrectomy is indicated. Then is metastasiectomy is indicated in metastatic renal cell cancers? Yes. So studies so far done has reported a significantly longer median overall survival and cancer-specific survival following complete metastasiectomy. But if you do a partial or if you do not do a metastasiectomy, the overall survival and cancer-specific survival median rates are significantly lower. In this study, it was increasing up to 40 months compared to 14 months of not doing metastasiectomy. And so therefore, if you are having any resectable metastatic which can be completely taken off, then we should offer the patient metastasiectomy. And preoperative embolization of metastatic foci has also shown to reduce blood loss and pain with regards to surgery, but it does not completely resolve the metastatic foci. So then my next topic would be systemic therapy for advanced metastatic renal cell cancers. So this systemic therapy, the evolution was like previously. Initially, the chemotherapy has been tried, but it has shown that chemotherapy has no added benefit with regards to overall survival in patients with metastatic clear cell renal cell cancers. And then they have moved on to targeted therapies and interferon gamma monotherapies, and they have also been extensively studied. So so one study has, many studies has shown that targeted therapy is superior compared to interferon gamma monoclonal antibody therapy as well. So this is one of the benchmark studies, and one interesting study which had been quoted in EUA as well, the Checkmate 214 trial. It's a phase 3 clinical randomized clinical trial, and this has shown that the combination of these two monoclonal antibodies, ipilimumab and nivolumab, was associated with a higher response rate and a higher complete response rate, and a longer duration of response compared to sunitinib alone. And these two drugs were, but however, these two drugs were associated with grade 3 to 5 toxicity, including significant treatment-related deaths as well. Therefore, the EUA recommends that these treatments should be offered to patients in higher centers only, where the toxicity regarding these monoclonal antibodies can be managed safely. And a little bit about pathogenesis of renal cell cancers before I move into the targeted therapies. As my previous presenters discussed, most of the renal cell cancers, the pathway is based on one Lindau gene pathway. So therefore, there is high vascular endothelial growth factor and platelet-derived growth factor expression in these patients due to hypoxia inducible factor accumulation due to VHL inactivation. That will result in neoangiogenesis and cause cancergenesis. So then these targeted therapies are targeting these targeted therapy drugs are targeting all these levels, so that it will block the pathway, and then the angiogenesis and the carcinogenesis will be blocked. But this pathogenesis and the pathway has been described and studied extensively only in clear cell renal cell cancers. So we have extrapolated these findings into other subtypes of renal cell cancers. But however, there are no strong recommendations with regards to targeted therapy when you consider other subtypes of renal cell cancers like chromophones and other sarcomatoid variations. So these are few targeted therapy tyrosine kinase inhibitors, just to familiarize the names and the mode of action. And this is
Nalin,
This is one of the
so
yes, sir.
better than anything in this is better than sunitinib. Is having a less side effect. Because you know.
Yeah, that of course I'm not very sure, but if you consider
the pasopanib is having a better side effect profile than sunitinib. You all know that sunitinib is a standard TKI in our country, but pasopanib have a less side effects. Yeah.
And it can also be given as an oral drug as well, pasopanib. And this is the commonly used monoclonal antibody, bevacizumab. And these are some mTOR inhibitors which are commonly used and available in the market. And based on these findings, the EUA recommends primary as well as second line treatment for IMDC favorable risk and intermediate and high risk groups. So in this, you can see that they are starting with monoclonal antibodies combined, and then if it fails only, they go for sunitinib. That is for favorable or low risk categories. And similar regime of targeted therapy is given for intermediate and high risk categories, and higher group of targeted therapy is given as second line for these intermediate and high risk groups. Those are the summary, that is a summary available so far in EUA guidelines. So that concludes my
checkpoint inhibitor. What do you understand by checkpoint inhibitors? What is checkpoint?
Those are cell cycle check. There are certain cell cycle checkpoints where the cells have to pass through when they go through the cell cycle. So if you can block them in specific cancer cells, the angiogenesis and the carcinogenesis can be blocked.
Right.
Yeah, I think just for the benefit of the trainees, I just have a few of these trials just summarized for you all. If you can just, I'll try to quickly do it. If you can just see the presentation. So can you see the presentation? So, so there is a Carmina trial and the Certime trial, which you have to know. So what is Carmina trial? Carmina trial is just this is just a small sort of summary slide. So if you look at the Carmina trial, what they have done is, all these patients are metastatic patients. So they've done nephrectomy plus sunitinib combination and sunitinib alone. So if you look at the blue line and the red line, so sunitinib alone for metastatic renal cancer, whether it's combined with nephrectomy, it gives the same result. So the other important thing in the Carmina trial is the patients who are included are patients with high risk and intermediate category. So that is one thing that you have to remember. So based on that evidence, you can say if the patient is high risk or intermediate risk, there is no real benefit of doing nephrectomy or treating the primary if somebody asks you. Then when you go to the Certime trial, where what they have looked at is primary nephrectomy and then combine the TKI, or first give TKI and then do the primary surgery. So in that case, again, you can see whether it's deferred surgery or surgery upfront has no change in the survival, progression-free survival rate. So that's another important study that you have to remember in metastatic renal cell cancer. So those are the two important studies. Then I'll just touch up on this one. Now, as you all know, the molecular targeted therapy has been a game changer. So initially, we have been giving interferon. So if you look at the 50% survival rate with the interferon, it's about 5 months. But when you practice, when the paradigm shift of the TKIs, sunitinib, 5-year survival, 50% 5-year survival has jumped to more than 10 months. So that's a 100% improvement of survival. So that's one of the important studies that you had to mention in metastatic renal cell cancer. This is phase 3 trial of sunitinib versus interferon alpha. Then the other important study, as Gobi said, the sunitinib versus pasopanib. So if you look at, these are the commonly available drugs that we also have in Sri Lanka. So if you look at the sunitinib versus pasopanib, both of these are TKIs, but the side effect profile is, if you remember, sunitinib is skin, S for skin. So all these cutaneous side effects are quite debilitating in sunitinib, but you don't have it in pasopanib. But the downside of pasopanib is you can have liver function derangement. So patients with liver function derangement, you cannot give it, although it can be given as an oral treatment. So, but the survival rates are identical for both drugs. So then the last thing is the immuno-oncology. I think Professor Nevkar also mentioned this. So that's where your nivolumab and ipilimumab comes there. So as we all know, when in the there is a sort of well-known scenario that once you remove the primary, most of the time, if it is oligometastasis, some of the metastatic lesions started to regress. So the mechanism is that renal tumors secrete CTLA4 and PDL1 molecules. So these molecules will actually help the renal tumors or metastatic renal tumors to evade from the or escape from the host immune response. So when the primary tumor puts out a lot of CTLA4 and PDL1 molecules, they go and they cover the immune response so that the T cells cannot sort of identify and attack the tumor cells. So in immuno-oncology, you are giving monoclonal antibodies again against the CTLA4 and PDL1 molecules. These are the nivolumab and ipilimumab. So these things will further sort of make the tumor cells vulnerable for the host immune response, and then you can have a host immune-induced attack on the tumor cells. So that's why they are the secondary recommendation once the TKIs are failed. This is progress on the TKI. Thank you.
Thank you, Dr. Nisanda. There are a few questions for the experts. Nabil sir, if a patient come with the physical CT finding of oncocytoma, how to proceed?
I think Gobi sir has just left the discussion.
I think Anuruddha sir is here. Sir.
Yeah. Anuruddha sir is here.
Yeah. Still, I would like to do surgery and, if possible, to do a nephron sparing surgery, like enucleation.
Okay, sir. If you do a true cut biopsy and biopsy says oncocytoma.
Still, I am not happy, but I would proceed with the surgery.
Okay. Yes, sir. I think Dr. Nishanda says?
Yeah, I think Gobi, one of the problems with this true cut biopsy is whether the biopsy is really representative of the whole tumor. Because if you get an oncocytoma, one of the findings that they have seen is that in the oncocytoma, there could be some associated papillary renal cell carcinoma in some of the other focuses. So because of that, I think it's more preferable to go ahead with the surgery.
I read the paper you sent, Balagobi. But still, you know, renal mass, I am very reluctant to manage non-surgically.
Most of the people say go for the surgery. The reason is, as Alexander said, there are papillary variant of oncocytoma oncocytic variant of papillary carcinoma and oncocytic variant of or eosinophilic variant of clear cell carcinoma can be there. And sometimes they say they have a hybrid tumor. Inside the oncocytoma, there may be other histological type. So most of the people still believe to go for the surgery. But there is a tendency, new generation says immunohistochemistry, almost 100% can decide whether this is a oncocytoma or other cancer. But still, I think we have to proceed with the surgery. Trainees, do you have any other question to ask from the Anuruddha sir? Because he's an expert in renal cancer, have written so many papers. And he's have an interest in tumor thrombectomy, and I have seen sir doing combined surgery with cardiothoracic surgeons.
Balagobi, you didn't tell about the tumor thrombus, the characteristic of the tumor thrombus and the outcome?
Yes, sir. I want to just, I don't know whether you can see this slide. Can you see the slide?
Yeah.
We can see. Yeah, we can see.
So this is a slide from Tim O'Brien and his paper. He says there are two types of tumor thrombi he have seen. One thrombi is like a sausage, very rigid thrombi, and other thrombi is like a pittu, a very friable thrombi. And the median survival is about 55 months in sausage-like thrombi, and about only 8 months in friable thrombi. So I think Anuruddha sir will tell about his experience.
Yeah, I also agree. Actually, the friable thrombi are associated with high-grade tumors, Balagobi, so that they are very adherent to the IVC also, getting blood supply to the IVC wall also. But your solid sausage-like thrombus are generally associated with low-grade tumors, and they are not attached to the IVC, so that you can just pull it very easily. The others need IVC repair and all. I totally agree with this finding. This is what our experience is also.
Thank you, sir. And I hope that Dr. Nishant said about Libovich. Before that, yeah, can you see this slide?
Yeah, we can see.
Yeah, so prognosis, chromophore is better. Next is type 1 papillary. Then clear cell and type 2 papillary more or less same. Then the most dangerous one is collecting duct. Anuruddha sir, agree?
Yeah, I think Gobi, there's a rare variant of medullary that should come just I think just before collecting duct or just after collecting.
Yeah, okay.
Yes.
Then the Libovich, maybe this one is clear. So there are points for the T1 stage, and there are points for lymph node positive or negative. There are points with that less than 10 or more than 10 tumor size and ferment grade, and the tumor necrosis. This is the only scoring system that involves the tumor necrosis in the scoring system. And this, as Dr. Nishant said, I have realized going there, and I have not known this scoring system before.
Exactly.
Yeah.
Exactly. The same thing happens. So all the trainees who are leaving better get to know about this scoring system and the ferment grade very fluently before you leave.
So and you can see this is low risk mean if a patient asks, okay, I have a T1A tumor and how long I will survive. So you can say in 10 years you will survive. You have a 90% chance you will survive. If it's an intermediate risk like T2B or something, patient will survive about 60%. So I remember like this: 10-year survival for low risk tumor 90. Intermediate 60, high risk 30. So 90, 60, 30. Easily you can remember. So just remember about the Leibovitz model. Another equal model is, as you said, the University of California and Los Angeles, UCLA, also known as UISS. So that model is the other that's widely used by EAU as well. Then regarding the positive margin,
there is a concern. There is a concern about the UCLA model, which they have mentioned that the Leibovitz model is primarily for clear cell, and UCLA, they have considered all the others also. So there are a little bit of a confounding factors in UCLA. So maybe that may be the reason they are using the Leibovitz predominant.
And regarding the positive margin, radical nephrectomy, almost you can't get a positive margin if the tumor confined to the kidney. So partial nephrectomy, around 8% chance you have a positive margin. Then the cryo have a less chance than the RFA. So if you remember this slide regarding incidence of positive margin, so RFA more, cryo, then partial nephrectomy. And if someone have a positive margin after partial nephrectomy, just treat like another small renal mass, 1 centimeter, 2 centimeter, all depending on the size. So after surgery, positive margin, treat with the ablative treatment. After ablative treatment, positive margin, treat with another ablation or go for surgery. So after ablation, positive margin, another ablation or surgery. After surgery, positive margin, most of the time, go for ablation. Then, any other questions you guys want to ask from the expert? Trainees, Nalin and Roshan, Achudan, Ihan.
And we would really like to get the trainees' input and the enrollment in this whole teaching session. So that's what myself and Gopi was also talking about the other day, that we need all the trainees' input, not just the local trainees, so trainees who are in the overseas and who are just about to go. So your request and your whatever the input is highly sort of appreciated, because you are the one who are benefiting, and you should tell us what to do. Isn't it, Professor?
Yes, I totally agree. This is just our plan. They must now tell how to fine-tune this so that we can improve it further. And this is a very good thing that you started, Nishant and Balagobi. I must congratulate you all for doing all this for the sake of the training, which we should have started much earlier. But at least now we have started, we must be happy. Thank you very much for taking all the trouble. And we'll try to continue this somehow and try to improve it further. And we'll request the trainees to send an email or even a WhatsApp message in the trainees forum telling your views.
So, and the plan is the next month there will be a assessment on renal cancer. Okay. So we'll read about it, and we will make a MCQ or SBA paper, and we will send to them email just 5 minutes before our discussion. So they will do it in 1 hour. Then we will discuss the questions over the 1 hour. So that will happen the next month. Then thereafter, after the next month, there will be another topic like renal cancer, and topics should be come from the trainees. I think we have selected 12 topics. But so what's the topic you like whether it's a bladder cancer or prostate CA or BPH or stones or infection or radiology or female urology, pediatric urology, andrology, whatever the topic you all tell, then we will organize. And just remember, and this is all for you, that's the more positive and more energy should come from you, then we will work better.
True.
Nalin, anything you want to say, or Roshan, and
any just a suggestion, sir. Now, if we do a assessment next month, that will be only assessment. Then there will be no discussion. Is it possible for us to have this assessment
followed by discussion? Nalin, assessment followed by discussion same day.
Okay, that's good. That means we'll be discussing about
do you
another
want
topic.
another topic on next month or what?
That's what I was asking, sir. If we can now, if we can have another topic, say like bladder cancers next month, so that if we do the assessment and do it, the time would not allow us to do the complete session.
Yeah.
So is it possible for us to have this assessment in between so that every month we will be having a discussion on each topic so that we'll be able to cover 12 topics within 1 year? Otherwise, we'll be covering only 6 topics. Is it if possible? That would be good. If
more we work on us, yeah, we definitely will. Yeah, happy to do that.
Yeah, that's right. So if there is enthusiasm from the trainees, we are really happy because we just wanted to have something good out of this because we are doing nothing. I mean, we are expecting nothing. So if you are improving and if you are sort of having active discussion going on, and if you benefit from this, I think that is the best thing that Amrita sir, myself, and Robi can achieve. So yeah, I think we will look into that.
Yeah, we can have a shorter discussion and finish quickly.
Yeah.
Hello.
Yes, super. Yeah.
Yes, Supun.
Yeah.
Hello, Supun.
Of the hi sir. On the topic of the prognosis for for different types of renal cancers, I think Anuruddha sir will also bear witness about the idea that type 1 and type 2 papillary renal cell cancers are not really what it is in the literature. Traditionally, we tend to think that type 2 is always carries bad prognosis and type 1 is something good to have. But if you go through the literature, you can find that the comparison is not always justifiable because most of the type 1 tumors are detected at a very early stage, and most of them are found at T1 or T2 stage, whereas most of the type 2 papillary tumors were found at a much advanced stage, and the comparisons made in most occasions depends on the type of cancers and the stage at which they were picked up. So most comparisons depends on slightly advanced stage type 2 papillary cancer and a slightly early stage type 1 papillary cancer. So that there were few studies which have taken into account only the stage 1 or T1 tumors from both type 1 and type 2 papillary tumors, which detected no real difference in overall and cancer-specific survival in the long run. So I think that observation was also found in one of the other series, which I went through with Anuruddha sir. So it is not really justifiable to say that type 2 papillary cancers carries more worse prognosis than type 1. So do you agree about that? With that?
Yes, I didn't want to confuse the trainees, Supun, because our paper is still not published. It's an emerging concept actually. Now, all this time we thought papillary and renal clear cell were two different things. Then subsequently people found even papillary is a heterogeneous one, and they divided this type 1 and type 2. And there are even subcategories like oncocytic papillary RCC. And now people are realizing this categorization is not a perfect one, because what we use is H&E criteria staining, and therefore we may not be picking the real markers which really differentiate these categories. So there is some controversy.
We are basically moving from histology to immunohistochemistry to, I think, genetics.
Genetics, yes. One day it will be like that, yes. Yeah. It's coming through, but once we publish the paper, we'll tell them, Supun, otherwise Balagobi will hijack our theory and will publish a paper.
Thank you so much. And trainees, do you have any question? I think it's a time to wrap things up.
Yeah.
Must be tired.
I think the trainees should continue the questions and whatever their queries through the trainees forum WhatsApp group, so that we can actively contribute and you can actively learn. We can also learn.
That's right.
We can learn new things, and people like Supun can sort of give their novel ideas and things. So yeah, that will create a good spark, and sort of people will be more interested. So to wrap up things, I would like to thank the experts, Dr. Anurudha Begunasekara and Professor Neville Pereira. Thank you very much for spending your valuable time on this. It's been more than 2.5 hours. Thank you so much. And on behalf of the SLAU's president and the secretary, and the education committee, Balagovi and Dr. Ranga Vikramarachchi. So all of you, and most importantly the trainees, and you have done a wonderful job within a very short notice. You've done a wonderful presentation, and I'm sure you will benefit. And I'm sure a lot of you must have heard new things. So this is the time to go and read what you
I would
have.
say we are far better than
that is the idea.
Yeah, far better.
Absolutely, and really, I'm impressed to see the amount of the things that they have gone through. So definitely we can make a wonderful sort of thing out of this. So make sure that you carry on with the same enthusiasm, and we will try to deliver whatever you want. We will work more harder when your responses are sort of impressive like this. Thank you very much. Okay. Anything to say, Balagovi?
Thank you, guys. Thank you very much. So be active in that group and give your feedbacks. Thank you, guys. Good night.
Yes, please. Okay. Good night.
Good night.
Thank you very much, sir. Good night.
Thank you, sir.